Welcome back to my channel. I'm Jennifer Lyons and I'm a VTS in Emergency and Critical Care. And in today's video, we're going to be talking about blood pressure. Not just how to measure blood pressure, but what it is that is making the values that we're used to measuring and why all of this is important. Blood pressure is the pressure exerted by your blood on the walls of the artery, and it is the driving force for tissue perfusion, thus tissue oxygenation. Without oxygen, cells die, organs become damaged. And because our blood is the delivery mechanism for oxygen to our tissues, our blood pressure is the major determinant of how much oxygen is reaching our organs and reaching our tissues. So your blood pressure, and specifically your mean arterial blood pressure, is really the driving factor for tissue oxygenation. To understand blood pressure, we need to just review some basic cardiac anatomy. So I'm going to walk you through the flow of blood through the heart. Blood will travel from your periphery, from your core organs, into the vena cava. This is deoxygenated blood returning to the heart. It will return into the right atrium, go through the tricuspid valve into the right ventricle, where it will then pass the pulmonary valve into the pulmonary artery, which is the artery in your heart, or the artery in your body that carries deoxygenated blood. The deoxygenated blood will travel to your lungs, where it will become oxygenated. It will then go to the pulmonary veins, which is the vein of your body that is carrying oxygenated blood. It will go to the left atrium, pass through the mitral valve into the left ventricle, and then pass through the aortic valve into the aorta to send newly oxygenated blood into your periphery and into your organs. Not only do we need to understand this basic cardiac anatomy, but we need to understand the different phases of the cardiac cycle. The cardiac cycle can be broken down into systole and diastole. Systole is the time that your heart is spending contracting and moving blood out of the ventricles and into either the pulmonic or aortic arteries. Diastole is the time that your ventricles are spending filling. So you can think of diastole as a phase of rest or inactivity from the heart, because it's not contracting, but passively filling with blood. So diastole is the time that your heart is taking to fill with blood so that in systole, it can contract and move that blood forward. This is where the term asystole comes from. A is the prefix for without, systole is contraction, so without contraction means the heart is stopped. Blood pressure measurements are broken down into systolic blood pressure, diastolic blood pressure, and mean blood pressure. Systolic blood pressure is measuring the pressure exerted by the blood on the walls of the artery while the heart is in systole, so while the heart is contracting and the aortic valve is open. Diastolic blood pressure is the pressure exerted on the walls of an artery while your heart is in diastole. The aortic valve is closed and your heart is not contracting. Mean arterial blood pressure is the mean pressure that is being exerted on the walls of an artery throughout the cardiac cycle. Because your heart spends more time filling, more time in diastole, your mean arterial blood pressure will typically be closer to your diastolic blood pressure than it will be to your systolic blood pressure. We care about mean arterial blood pressure because this is the driving force for tissue perfusion and tissue oxygenation. And below a certain threshold for your mean arterial pressure, your core organs are not going to be receiving enough oxygen and therefore will be prone or susceptible to organ damage. Now, to understand blood pressure, to understand what causes blood pressure to be high or low, we really need to understand the physics of blood flow. These are some complicated concepts that we're about to go over, so try to stay with me. I'm going to try to break this down to make it a little bit more simple. For the determinants of blood pressure, we're going to break this down into a tree, with blood pressure being at the top. Your blood pressure is determined by your heart's cardiac output times the systemic vascular resistance that the blood is meeting. So next I'm going to break down the tree that determines cardiac output. Your cardiac output is determined by your heart rate times stroke volume. Heart rate, we all understand, it's the number of times your heart contracts during a minute. And it is determined by your autonomic nervous system, which is broken down into two components of our sympathetic nervous system, our fight or flight response, and our parasympathetic nervous system, or our rest and digest response. Stroke volume is the volume of blood that is moved out of our heart during each systolic contraction. Understanding stroke volume can be a really difficult concept, but we're going to try to break down the determinants of stroke volume, which are three categories: your heart's preload, your heart's contractility, and your heart's afterload. Preload is the amount that your ventricle is stretched during diastole. So your preload equates to your end diastolic volume, which you'll see abbreviated as EDV, because at the end of diastole, when your heart is done filling, is going to be when your ventricles have reached their maximal stretch, because that's the maximum amount of blood that'll be in your heart before your heart contracts. So your preload is the stretch of your heart before it contracts. You can see why stroke volume would be affected by the amount of blood in your heart before it contracts, because if there's more blood in your heart before it contracts, there's more blood moving out of your heart. The second factor that affects stroke volume is contractility, and this is the amount that your heart contracts during its systolic contraction. If your contractility is low, you'll be able to push less blood out of your heart than if your contractility is high and you're able to push more blood out with each contraction. The third factor that affects your stroke volume is your afterload. Your afterload is the pressure your heart is working against to push blood out of it. So when it comes to your left ventricle, your afterload is the aortic pressure, because it's the pressure that is already existing in the aorta that the ventricle has to push against when it pushes blood out of the ventricle. You can see why afterload would affect your stroke volume, because if your afterload is high, if the pressure, the aortic pressure is high, your heart is going to have to work harder to push blood out of the ventricle and into the aorta. And now back to the top of our tree, our systemic vascular resistance. Your systemic vascular resistance is the amount of pressure that your vasculature puts on your blood, because not only is your blood applying pressure to the walls of the arteries, but the walls of the vessels that the blood is in are also putting pressure back on the blood. So your systemic vascular resistance is going to change based on the size of the vessels that the blood is flowing through. Systemic vascular resistance is dictated by systemic factors and by local factors that are telling the vessels to either be vasoconstricted, small, or vasodilated, large. So in short, those are all of the things that are controlling our blood pressure. This all matters because our body has to control all of these factors, and low blood pressure or high blood pressure can stem from any problem with any of them. For the sake of today's video, we're mostly going to be going over hypotension and causes of hypotension. In general, you can think of causes of hypotension being one or multiple of three different factors. One, a reduction in cardiac function. Two, a reduction in preload. And three, a reduction in systemic vascular resistance. So let's break those three things down and talk about how each of them causes hypotension. One, a reduction in cardiac function. By reducing your heart's ability to move blood forward, you are reducing your cardiac output. Loss of cardiac function can be either primary, coming from a cardiac specific disease, or secondary, coming from a systemic disease. An example of a primary loss of cardiac function would be a pet with a severe arrhythmia that is not able to move blood out of its heart as efficiently, or a pet with DCM, dilated cardiomyopathy, that has a reduction in contractility and is not able to move blood forward. Examples of secondary losses of cardiac function include severe electrolyte abnormalities that prevent the heart from pumping as it usually would, or sepsis, where you have severe inflammatory mediators and cytokines that are reducing your heart's ability to have good cardiac function. So our second potential cause of hypotension, a reduction in preload. As I kind of touched on earlier, if you're reducing the amount of blood in your heart, you're reducing the amount of blood your heart can move out of your heart. Less blood in your heart means less blood to pump forward and a lower blood pressure. Causes of a reduction in preload can include hypovolemia, so a smaller total blood volume that can be caused by severe dehydration or blood loss from trauma or from an abdominal mass that's now bleeding and causing a severe hemoabdomen, or from obstructive loss. An example of obstructive loss would be a pet with a GDV that has reduced venous return to the heart, or a dog with pericardial effusion that is not able to, their heart is not able to fill as much because of all of the blood or fluid that's in their pericardium preventing their heart from filling. So our third potential cause of hypotension, a reduction in systemic vascular resistance. Part of our body's regulatory system to help regulate our blood pressure is to either dilate or constrict our vessels. Anything that damages your body's ability to do this, or any systemic mediators that are causing vasodilation or vasoconstriction, are going to alter your blood pressure. Examples of a loss of systemic vascular resistance would be a pet with sepsis that has, again, these inflammatory cytokines, inflammatory mediators, or a pet that is undergoing severe anaphylaxis for the same inflammatory reasons. Our vessels will dilate instead of constrict, and we will have a loss of blood pressure. In dogs and cats, you can consider your patient hypotensive when their mean arterial blood pressure has dropped below 80. Your pet is at risk for organ damage, specifically renal damage, if their mean arterial blood pressure falls below 60. In cases where we don't have a mean arterial blood pressure measurement, you can consider your pet hypotensive if their systolic falls below 90. And again, like everything else in my videos, these numbers are going to change based off the reference that you're reviewing. So these are just the numbers that I use to define hypotension. These numbers are in millimeters of mercury, which is abbreviated mmHg. And the reason the blood pressure is measured in millimeters of mercury is because way back when they were starting to measure blood pressure, mercury pressure meters were the most accurate and the most widely used. And now in today's medicine, millimeters of mercury is still the standard unit used for measuring pressures. The next part of this video is going to be about how to measure blood pressure. We're going to be talking about the two ways of measuring blood pressure indirectly and the gold standard of how to measure blood pressure directly. The gold standard for measuring blood pressure in the veterinary setting is going to be by direct arterial blood pressure monitoring. For direct blood pressure monitoring, you will be placing a needle or catheter directly into an artery, hooking that up to a transducer, which uses a pressure sensor inside it to feel how much pressure the artery is putting on the transducer. And it will then take those inputs and turn them into electrical signals to give you a pressure. The benefit of direct blood pressure monitoring is that you get real-time measurements of blood pressure in systolic, diastolic, and mean blood pressure. This is severely helpful for monitoring hypotension in our very critical patients. So our septic post-ops, our severe GDVs, our severely sick hemoabdomens or renal failure patients or pneumonia patients, being able to have real-time information about what their mean arterial blood pressure is doing, what their systolic blood pressure is doing is invaluable. The downside of direct blood pressure monitoring is that it is invasive. You are placing a catheter into an artery, which is technically challenging. Learning to place an arterial catheter was one of the skills I had the most difficult time with when I was accomplishing my BTS, because it's just technically hard. The artery does not like to let a catheter in. Usually it's pretty easy to hit an artery with a needle, but advancing a catheter through an artery is very technically challenging and very difficult, especially in your small patients. It's also painful. There's a lot of nerves right there, and arteries are very close to the bone. You may accidentally hit the patient's bone when you're trying to place your catheter. It is not comfortable for our pets. Most of the time when I'm placing an arterial catheter, I prefer to do it when the pet is being anesthetized for surgery, if at all possible. There is also an increased risk of thrombosis to the vessel that you're using, especially in very small pets and in cats, because cats fail to establish collateral circulation. So typically in cats, we don't leave our arterial catheters in for more than about 12 to 24 hours. You also need a special monitor to be able to measure direct blood pressure. You need a monitor that's able to connect to invasive blood pressure monitoring that will connect to your transducer, and these are not cheap and not every monitor has that connection on it. The typical arteries used for arterial catheterization are the dorsal pedal arteries and the tail artery. The much more common methods of measuring blood pressure in the veterinary setting are indirect blood pressure measurements. No matter what method you're using to measure indirect blood pressure, you will be using an occlusion cuff. An occlusion cuff is the blood pressure cuff, the cuff that goes around your arm or your pet's limb that you will put pressure into to occlude the artery. It is very important in obtaining an accurate blood pressure to choose an appropriately sized occlusion cuff. Your occlusion cuff should be 40% the circumference of the limb that you're using it on, so roughly slightly less than half the width of the limb. It's also important that your occlusion cuff is placed correctly, meaning if you look on the inside of your occlusion cuff, you will see that there's like an index or a range in which your one side of your cuff should fall into to show that it fits appropriately. So when you're placing your cuff, make sure you're looking at the inside of the cuff and see that you are indeed hitting that reference range. If your occlusion cuff is too tight, your blood pressure is going to read artificially high. If your occlusion cuff is too loose, your blood pressure is going to read artificially low. So be careful to make sure that you use the right sized cuff. In pets that are hospitalized, it's beneficial to use the same leg and the same size cuff every time. So make sure you're not only choosing the correctly sized cuff, but you're writing down what cuff you used and what leg you used it on. Typical arteries utilized for indirect blood pressure monitoring are the pedal and palmar arteries, your dorsal pedal artery, and your tail artery. The two most common ways of measuring indirect blood pressure are use of an oscillometric machine and a Doppler machine. Oscillometric sphygmomanometry measures the oscillations that your blood makes as it passes through a vessel. These oscillations are then converted through an algorithm into a systolic, diastolic, and mean arterial blood pressure. The benefits of using oscillometry are that it is technically easy. You only need to be able to know how to size your cuff, know how to put it on the patient, and then press the start button on your monitor. The other benefit is that you get all three readings for systolic, diastolic, and mean arterial blood pressure. You also do not have to maneuver or handle your patient after you put the cuff on. If your pet is comfortable sitting as they are, you're able to put your cuff on and back away, which will help prevent iatrogenically high blood pressure readings from anxiety. The downside to oscillometry is that it's not incredibly accurate in small animals, especially cats. So animals less than 5 or 10 kgs are not going to get accurate oscillometry readings. In addition, it's not very accurate in pets that are hypotensive or pets that have underlying arrhythmias. The second method for measuring indirect blood pressure is through Doppler ultrasonography. Doppler ultrasonography measures blood pressure by emitting ultrasonic sound waves out of a probe, also called a crystal, which will bounce off the blood as it passes through the artery, bounce back to the probe or crystal, and will tell you at what pressure the blood is passing through the occlusion cuff. Obtaining a Doppler blood pressure is slightly more technically challenging than obtaining an oscillometric blood pressure, because not only do you need to put your occlusion cuff on, but you need to be able to find the artery with your blood pressure crystal. This is often easier said than done, especially on large patients or on hypotensive patients. The first time I ever took a Doppler blood pressure was actually during an interview. I'd never done it before. I'd seen it done and I kind of had a general idea of how to do it, which is not the situation you want to be in. So make sure you've watched this video to the end and learn how to measure a Doppler blood pressure. The benefits of Doppler ultrasonography blood pressures is that they are more accurate in small and hypotensive patients. The drawbacks are that due to the amount of time you have to spend with the patient, you can get iatrogenically high readings from anxiety or from nervousness. And it only gives you information about the systolic blood pressure. It does not give you a systolic mean and diastolic blood pressure reading. Some studies have shown that Doppler blood pressures may be more reflective of mean arterial blood pressures in cats. This is still undergoing research, but keep in mind that your Doppler blood pressure may reflect mean arterial blood pressure as opposed to systolic blood pressure in cats. I'd like to stop here for a moment to talk a little bit about pulse pressure, which is palpating for pulses. The reason I wanted to talk about this here is because I see a lot of people equate a good pulse pressure or a good pulse with good blood pressure, and that is not necessarily true. Because your pulse pressure, when you're manually, digitally palpating your pulses for your patient, you are feeling the difference between their systolic and diastolic blood pressure. So the difference between the high point and the low point of the blood pressure in their artery. Therefore, that is not equivalent to their blood pressure. You can have a hypotensive patient that has a low systolic blood pressure and a low diastolic blood pressure, and you can feel pulses. So please keep in mind when you are palpating for pulses and you feel pulses, this does not mean your pet has a normal blood pressure. You do still have to measure a blood pressure. However, if you're palpating for pulses and don't feel pulses, your pet is most likely hypotensive. So now I'd like to go over how to obtain an indirect blood pressure measurement. First, you will select your appropriately sized occlusion cuff, making sure that you're measuring approximately 40% the circumference of their leg. You should put your occlusion cuff on, not too snug, not too tight, and you should make sure you're putting it proximal to the artery, so closer to the pet's body than the artery that you're measuring if you're doing a Doppler blood pressure. Try to ensure that your patient is sitting down. They're preferably laying down so that the artery that you're measuring is roughly at the level of their heart to get the most accurate blood pressure. If you're measuring an oscillometric blood pressure, all you need to do at this point is connect your cuff to your machine, make sure your pet isn't moving, press the start button, and you're good to go. You're gonna get a blood pressure reading. They take a while and your pet does have to sit still the whole time, so this process can still take a couple of minutes. You just have to sit there and wait. Your anesthetic monitor will show that the blood pressure is going high, then low, as it measures the systolic and diastolic pressure, so you just have to wait, and you will hopefully get a reading. If there's too much movement, you're gonna get a movement artifact and your blood pressure won't give you a number. It'll say if the pulses are weak, pulse too weak, not able to measure. So there are a couple of different errors that you can get from your machine that you'll either need to try to retake it or switch to Doppler blood pressure to see if your pulses are actually too weak for it to measure. If you're obtaining a Doppler blood pressure, you're not done. You're going to connect your occlusion cuff to your sphygmometer, which is the little part that you push pressure into to blow up the cuff. You're going to palpate for the artery that you're going to be using to measure. Once you know roughly where you're going, you can either shave the hair away or apply alcohol to wet the hair. I used to do the shaving method, and then over the years I've just found that it's unnecessary. You usually don't have to shave to get good contact to the crystal if you use alcohol. The benefit of not shaving is that you're not iatrogenically raising your patient's blood pressure by putting the clippers on them, because as I'm sure we all have experienced, the clippers are often the worst part. So I like to just make sure I keep an alcohol bottle handy with my Doppler machine so that I can quickly wet the area with alcohol. If they have long fur, I'll try to part the fur so that I can get good contact between my crystal and the patient's skin. So next you're going to be putting a dollop of ultrasound gel on your crystal. Make sure you're putting a good amount. If you don't have enough, you're going to get crazy static, or you're not going to be able to hear anything. So a good dollop of ultrasound gel. Put that on your patient's skin where you've applied the alcohol or where you've shaved the area. After your crystal is on their skin, you may turn your Doppler on. I recommend doing it after, because if you put the crystal on your patient's skin after you turn the Doppler on, you're going to get a lot of horrible static and it's not going to be fun to listen to. So I put the crystal on the patient's skin, try to keep it nice and still, turn on your Doppler. If the volume's really far down, you may need to turn your volume up enough until you can hear the artery pulsing. If you don't immediately hear the artery pulsing, you may just need to move your crystal around until you find it. If you're measuring a pedal or palmar artery, you may need to move either more medial or more lateral until you find the vessel. Do this slowly, make slow adjustments, because you have to give your machine time for the static to die down, and you have to just give yourself time to see if you're hearing the pulse. If you're moving too fast in a pet that is bradycardic or a pet that has a naturally low heart rate, you may just be missing the pulses. So make sure you're moving slow, and just with really small movements, move your crystal around until you can hear the pulse. This is easier said than done and kind of just takes some practice. Keep in mind that if you are pushing on their foot too hard with the crystal, you may occlude their artery, especially in small pets. So you want to hold the crystal to their skin just tight enough that you have good contact, but not tight enough that you may occlude the artery. Once you've found your pulse, you're going to inflate your sphygmomanometer, which will inflate your cuff to the point that you no longer hear the pulse. Then you'll let the air out of your sphygmomanometer until you can hear the pulse again. And this will be your systolic, or depending on your reference, the mean blood pressure. And you're going to repeat this 3 times. Sometimes I will repeat this process more than 3 times if I'm getting really different numbers, which you may do when your pet is hypertensive. So I've had severely hypertensive pets where I've gotten 180, and then I got 210, and then I got 220, and then I got 190, and then I got 200. And you just have to try to give your pet time to calm down. Slowly repeat this process until you're getting roughly the same number every time. Be sure to release the pressure on your sphygmomanometer between readings. If you're not releasing the pressure, you may read artificially high pressures, and it's going to be really uncomfortable for your pet, because again, you're occluding blood flow to the distal aspect of their limb. Their limb can go numb, it'll start to tingle, it won't be comfortable. So for accuracy, for comfort, deflate your sphygmomanometer between each reading. All right, well, that is all I have for today on the determinants of blood pressure and how to measure blood pressure. Stay tuned. Next week, we'll be learning about pulse oximetry. If you've made it this far, as always, please like this video, subscribe to my channel, and I will see you next time. Oh. You are so cute. You huge little monster.
Sit. Wait. Take it.